Daddy. Everybody, can you please mute your microphones when you join? Good evening, everyone, and welcome to another session of Intellectuals Campus. I would like just to remind everybody of their Zoom functions. Can you please make sure your microphones are on mute? And our admin team, can you please mute anybody who unmutes themselves? And if they don't mute, can we just remove them to the waiting room until such time as they rejoin? I'd like to introduce everybody to our speaker tonight, who is Dr. Debru Negash. He has a myriad of qualifications, and he trained initially in engineering and then went on to do a medical degree at the University of Utrecht in the Netherlands. Sorry, just hang on a second. I'm having a problem with feedback. So Dr. Debru Negash had got a B.Sc in public health engineering from Gondar University before proceeding to the University of Utrecht in the Netherlands, where he studied medicine and qualified as a medical doctor. He subsequently chanced to win the British Council Scholarship and further had postgraduate degrees in tropical medicine and occupational medicine from the London School of Hygiene and Tropical Medicine and the University of Birmingham, respectively. He has worked extensively, serving as the ILO Senior Medical Advisor for the Africa region until 2014. He has worked in various capacities for the Dutch Ministry of Foreign Affairs as an expert, and after working for a year in The Hague, he opted for assignment overseas. He has since served as a clinician and an academic in tertiary institutions in Kenya, Malawi, and Zimbabwe, and he currently lectures in infectious disease at the University of Zimbabwe. He had a year-long stint working in India, Nepal, and Sri Lanka. Dr. Negash's expertise extends to family planning, medical education, leprology, tuberculosis, tropical ophthalmology, and aviation medicine. And the most impressive thing about Dr. Negash is he's also a qualified private pilot. He has a vast amount of experience. I pre-recorded this meeting and I learned an incredible amount in an hour, and I'm really looking forward to sharing the recording with you. I'd just like to remind you that our themes for 2024 are constructive controversy. We don't only look at one way, and our big theme for 2024 is ASAP, which doesn't just stand for as soon as possible, it stands for African solutions for African problems. And with that, I'm going to stop sharing. And Pride, can you please play the recording? Good evening, everyone. We've introduced Dr. Debru Negash, and this is our next in a series on infectious disease and combination therapy. We've covered HIV, we've covered TB, Helicobacter, and now we're moving on to leprosy. So as well, just to remind everybody about the chain of infection, there's an infectious agent, there are reservoirs, a portal of exit, a means of transmission, a portal of entry, and a susceptible host. And at the end of this, we will also be discussing the portal of entry. But for today, we are going to focus on leprosy. So the title of the talk is Leprosy, Should It Be Included in the Differential Diagnosis? Dr. Debru Negash did his original medical degree in the Netherlands. He went on to do an M.Med at Birmingham, and he did his master's in infectious disease in tropical medicine in London. And he also has a diploma of tropical medicine and health from the Royal and Hygiene from the Royal College of Physicians in the UK. So he is an infectious disease specialist. We've discussed experience-based medicine, and judging by the color of your hair, my color is artificial. But so I'm artificially blonde because my color is not dissimilar to yours. But you've been in this game for a very, very long time. Dr. Negash is originally from Ethiopia and went to Holland in what year?
In 1976.
So I was 11 years old in 1976. And he's obviously got a huge amount of experience in India and in Africa with this condition. So Mycobacterium leprae.
In Europe as well, by the way. In Greece, Holland, in England, leprosy. Yeah.
Well, I'm going to hand over to you as a presenter, and we'll start with the slides, and you can educate us on Mycobacterium leprae, which is, I think, something that most doctors completely forget about in a dermatological condition, and we forget about it in neuropathy, and we forget about it in systemic disease. So I'll hand over to you, and please just tell me when to advance the slides.
Thank you very much, Jackie. It's an honor to be able to say something on leprosy. It's such a broad subject, so we have probably little time to do everything else. Briefly, Mycobacterium TB, leprosy is the etiological factor. Maybe I should say something about the history itself.
Carry on.
Now, leprosy is a very enigmatic disease until probably about 100 years ago. It was a major burden of infection in Europe as well. Historically, I think it was around the 15th century when the United States was manned by Europeans. What they did was they actually exported virtually every single leprosy patient to the United States. So that was a physical isolation. One of the ways at the moment we do what they call chemical isolation. Then they did physical isolation because people were living under very crowded conditions. So as they were sent to the United States, people were spread across the entire continent, and the disease died actually naturally. And there weren't many individuals to infect another person with.
Well, just interrupting you, if you actually go back, we were talking about the history. And in actual fact, lepers are described, you said Ethiopia has the oldest form of Christianity. And in fact, lepers were described in biblical times.
Oh, absolutely. Actually, it goes much in old. I think it has been described in Sanskrit several thousand years ago in India. And in, I think, the Jewish book, is it
the Torah?
The
Torah.
The Torah, I think either is the Torah, but also in the, we have got the New
Testament?
The New Testament, the Old Testament. It has already been in the Old Testament as well, but it has been as old as humanity itself. It's a very, very old disease. And there are quite a number of references in other books as well, not only, I think, probably in Quranic versions as well. So it's a very old disease. I had the good fortune of spending 3 months in India when MDT was introduced. Until then, there were about 12 million individuals, 4 million of which were in India with leprosy. And over the last 40 years, the number of patients had dwindled to less than 200,000 per annum. So a drastic improvement, really.
So when did you go to India?
In 1981, I did my electives. I was a final year student. So I did my electives in India. And that was when multi-drug therapy was, until then it was with monotherapy, dapsone alone. That was when they started.
My experience from London was that in HIV, they discovered multi-drug therapy in 1995, 96.
Much earlier. This was actually, you see, those fools, they discovered Victoria Falls as well.
You have to be politically correct on this one.
Listen.
So we're getting back to intracellular organisms.
This is an intracellular, non-sporing and non-motile acid-fast pathogenic bacterium, which has a tendency of, it has a predilection to multiply in colder areas of the body, not only colder areas, it likes colder temperature as well. Virtually all other organisms, except for influenza, do like to replicate under very, very human-like 37 degrees or thereabout. This particular one, microbacterium, it does well in around 25 to 30 degrees. So it likes not only cooler temperature, but it multiplies on colder areas of the body. The cornea, by the way, is the coldest part of our body. The cornea.
It doesn't have a blood supply.
Exactly. It does not have blood supply of its own. It gets blood supply, I mean, oxygen from the nasocorneal junction, actually, from that area by diffusion. So the other areas, the earlobes are also pretty cold, the fingernails, the nose, these are the colder parts of the area where the Mycobacterium leprae multiplies in the Schwann cells of the nerve fibers, actually, nerve teeth. So we said they like colder areas of the body. They multiply in colder, I mean, lower temperature, as opposed to, say, for instance, TB, which likes a temperature of around 37 degrees. Another interesting thing is its multiplication time, which explains, well, we didn't say something about the incubation period. The incubation period is between 12 to, say, about 2 weeks, as against less than a day for Mycobacterium TB. And that's why the disease has such a very, very long, what do they call it? Between infection and the emergence of the disease, it can take as long as 20 years.
Oh my goodness.
And that is explained by the generation time, the multiplication time for Mycobacterium TB is at less than a day, between 18 hours to 24 hours, as against 2 weeks for leprosy. And imagine viruses multiply in seconds. Pneumococcus, for instance, multiplies in about 20 minutes. So that's why you can develop, if one is exposed to Mycobacterium, I mean, to pneumococcus infection today, within probably a few hours, you could develop florid pneumococcal pneumonia, whether it is lobar pneumonia or a much more generalized one. Within a day, you can develop the condition. In TB, it can take months. So that explains why it can take about 20 years.
So I could have been exposed 20 years ago and I might only develop symptoms.
Absolutely,
now.
absolutely.
And especially if my immune system was suppressed.
Absolutely. And
that's so interesting.
Yeah, so so that is something about the disease. It is not actually, it is, we get the disease through the respiratory system. Quite a number of people until quite recently believed it was cutaneously acquired, but it isn't. It is non-motile, so it cannot, unlike syphilitic Treponema pallidum, for instance, or anthrax, or Treponema cruzii, the Latin American one. It comes from the feces of the bug itself. As it itches, we scratch it and we introduce it to the skin.
But leprosy is inhaled.
Leprosy is inhaled. It is through inhalation.
And then it enters circulation and it goes to the skin.
It can, well, entering the circulation does not make it any nerve. It's the nerves. Actually, it's the peripheral nerves that are affected. It does not go, the internal organs are affected as a result of immunological reactions, not as a result of the TB itself, the lepromatous, the leprosy bacilli itself.
So you would inhale it. It would go into circulation and would go to your Schwann cells.
Actually, well, you inhale it's actually the nasal, the nerves, the nasociliary nerve, for instance, are afflicted. And by extension, quite as they extend through the neural areas, and it's the cutaneous nerve. So they go into the, if say, for instance, the eye is affected as well by leprosy. So the infection, the macrophages are the ones that actually carry them to the different parts of the body. The macrophages.
So it comes into the nasociliary area.
Yes. The macrophages takes them to the different parts of the peripheral nerves. And the Schwann cells are the ones, they multiply, and they are carried by macrophages to those areas. They multiply and causing direct neural affliction as a result of, and as well as by stimulating the immune system. We shall go into that a little later.
Okay. So it gets to the different manifestations.
Yes.
The skin, to the peripheral nerves, to the nasopharynx, the ocular and the systemic system. It gets there through the Schwann cell.
Through the Schwann cells, actually, it is the nerves that are affected. The peripheral nerves are the greater auricular nerve, which I think if we can find to show that. The greater auricular nerve around the eye, it isn't only the peripheral nerves, the cranial nerves, the trigeminal nerve, particularly the ophthalmic branch of the trigeminal nerve is affected, sensory component. As you know, the trigeminal is a mixed nerve. The maxillary and mandibular ones are motor. The ophthalmic branch is essentially sensory. That is affected by leprosy.
Okay. And so you need to know your cranial nerve anatomy.
Absolutely.
To diagnose
exactly
leprosy.
Yeah, so the facial nerve as well, the motor component, the facial is actually motor. So much of the conditions we find around the face are a combination of two neurological afflictions. The sensory component is the ophthalmic nerve, the motor component is the facial nerve. So a combination of the two can render the eye completely blind. We shall
do that. Yeah. So let's go through the skin manifestations, because those are the most well-known ones. And you told me earlier that depending on the immune response, you will get different manifestations.
Exactly.
So could you explain in the skin? And, doctors' groups often put pictures, and people send people to a dermatologist very quickly, when probably a lot of GPs are seeing this all the time and not even realizing they're seeing it, and they're diagnosing it as vitiligo, or they're diagnosing all the other dermatological conditions, and they're not staining for leprosy.
Exactly. Yeah.
So can you explain the different manifestations?
Now, this is a case of the slide on the top is a tubercular type of leprosy. As you can see, it is circumscribed. It's a macular lesion. Macular means flat. As you can see, it's fairly circumscribed. Now, it is anhydrotic. In other words, the skin is dry, there is no sweat. It is also anesthetic. So if with the cotton wisp or with anything, actually, if we run through it, the patients can't tell whether or not you have taken.
So basically, it's a clinical diagnosis.
It's a clinical diagnosis.
So if somebody used diagnosis tinea vesicolor, for example,
Yes.
would they be able to feel?
Oh, absolutely. Every other condition, yes. Every one of them. There is another condition called a congenital, I'm trying to remember.
Yeah, it's something that is probably
Yes.
so rare.
Yes, sorry, I chanced to see one in India. They're a little boy of about 6. They brought in this particular, because congenital anesthesia, but both his entire body was anesthetic.
That's what you say.
So, but this is quite distinct. These areas are completely dry. You can make them run. Every single area around will be sweating, but that particular area is spared.
So no sweating and no sensation.
No sensation.
That's very, very.
That is very, very unique. It's pathognomonic.
Now, the tuberculoid type doesn't have that many microorganisms on biopsies.
Exactly.
So this you would only really diagnose clinically.
Clinically, yes. Now, what happens is TB, leprosy is reckoned to be a polar disease, or and they call it spectral disease. It ranges between 2 poles. The one pole, the tuberculoid, is where there are very, very scanty lesions as a result of a very, very strong immunity. When the immune system is strong, you have got very few lesions. So in other words, on the tuberculoid range of the disease, there are few Mycobacterium leprae, a very, very high cell-mediated immunity, and very, very low amount of humoral immunity. Humoral immunity, as you know, is a function of massive antigen. If there is a massive antigen production, you would have a proportionate amount of humoral immunity. But because tuberculoid type has very, very little microorganism, there is very little antigen exposed to them. So there will be very little humoral immunity. So as opposed to lepromatous, in the lepromatous range, because the body has very little immune system left, cell-mediated immunity, the Mycobacterium leprae multiplies by leaps and bounds. And that would mean a massive amount of antigen. So because of the massive amount of antigen, you have got massive amount of humoral immunity, which actually does not do any good at all, because humoral immunity does not affect something intracellular. Intracellular infections are managed by cellular immunity, by cell-mediated immunity.
That's a really important point in the current global context, because we're trying to induce humoral immunity for COVID when it's an intracellular organism. So are you saying basic infectious disease, it means that humoral immunity will not kill an intracellular?
In the case of, yes, in the case of TB, malaria, leprosy, it has proven to be the case. Well, I know humoral immunity can provide some sort of, through opsonization, the macrophages can isolate that, whatever comes into the system. But in Mycobacterium leprae, that does not, in fact, the greater the humoral reaction, the greater the damage. The damage is. So
that's very interesting.
Yeah.
So if this was an HIV patient who was progressing, you would expect initially a tuberculoid reaction, progressing to a borderline, progressing to lepromatous as cellular immunity dropped.
Absolutely. In fact, other conditions, pregnancy, for instance, immunocompromised woman, poor nutrition, I will go through that actually, poor nutrition, concurrent infections, they would all compromise the immune system. So someone who has got, for instance, a tuberculoid leprosy, a pregnant woman who probably has tuberculoid leprosy initially, When she gets pregnancy, the condition can get worse. We call it an upgrading reaction. She can actually go into a borderline tuberculosis, which means her immune system has been waned as a result of the pregnancy. So she would have a much worse outcome from the tuberculosis type. She can develop progressively into a poor borderline one, or even a borderline one, which means that the mycobacterium would increase in number, and the immune reaction, the humoral the response would as well increase. So not only that, we'll go when we deal with reversal reaction, we can talk a little more about that. So tuberculosis, by and large, is a condition whereby the immune system is fairly strong. 95% of humanity is spared. We do not develop, even if we are exposed to leprosy, 95% of the individuals exposed to leprosy never develop leprosy. It's about 5% who develop the leprosy. Even among those who have got this, among the 5%, it is those who have got the strongest immune system that develop the tuberculosis type. The one that come after that is a borderline tuberculosis, and then comes the borderline, the borderline lepromatous. Eventually, the ones who have virtually no cell-mediated immunity end up developing lepromatous leprosy, for which virtually are unlimited. So a gram, for instance, of tissue can have as much as 100 million Mycobacterium leprae, from 1 million to 100. A gram of lepromatous lesion can have as much as that.
So I would, in my limited experience, probably have diagnosed this as a fungal infection.
Absolutely. It looks like fungal infection. What makes it different from fungal infection, I would have, it could look like lichen planus, or in fact, discariasis as a result of
the tinea
versicolor.
Yeah, or the tinea, the one that expands.
Absolutely, yes.
So if this was, we call it tinea pedis or wherever it was.
Yeah.
So would you say that the differential
diagnosis absolutely
would be leprosy, and the way you would distinguish it is that the center would be anesthetic?
Yeah, the center would be anesthetic. In this particular one, as you can see, we have got some central healing. As you can see, the margins are erythematous, which is fairly well circumscribed. And you have got, as you can see, raised borders in this area. And the other thing, obviously, is it is not only dry, it is completely anesthetic as well.
So the only way to distinguish that really would be to do a skin scraping, or and you would have to ask for specific staining with Zeal-Nielsen.
Well, this one may not turn out to be positive, actually. It is BT, but borderline tuberculosis. It can, the number of microorganisms TB, not that it isn't there. It may not actually, just like stool exam, for instance, unless you concentrate stool, you may miss a particular type of. So similarly, you can take, unless you take a couple of samples, you may not actually find Mycobacterium TB. Pathologically, you can recognize it as TB.
Well, that is leprosy.
Leprosy, yeah. So, but clinically, the lack of skin, the anesthesia and dryness of that central area in itself are virtually pathognomonic. And there are some nerves as well. This is an arm. So the ulnar nerve as well, actually, in the ulnar sulcus, is fairly enlarged. So that you could have enlarged nerve. Higher up, you would also find the radial nerve is quite inflamed as well. So the median and ulnar nerve are affected as well in those conditions. Now, this is a case of borderline tuberculosis, a very, very large lesion, flat and hypopigmented centrally. At the margins, is fairly inflamed, and this is a case of borderline tuberculosis.
Okay. So we've done borderline tuberculosis, then it goes through to borderline lepromatous, through borderline.
Yeah, borderline. Now,
so this is a case of borderline. What makes this different to the borderline tuberculosis?
Again, as we said, essential tuberculosis is manifested with very few lesions. What it means is there are few mycobacterium leprae in those individuals. Similarly, in the lesions, there are very few mycobacterium leprae. The next stage is borderline tuberculosis, where the cell-mediated immunity is it's less than tuberculosis, but better than borderline. So there are more mycobacterium leprae, but the immune system is less.
Okay.
So that indicates why you have got quite a number of, as you can see, it is teeming with lots of lesions. And invariably, you can find mycobacterium leprae in these ones. If you take samples from the skin, you can find borderline. And borderline, you can find the lesions under Nelson stain. And this actually comes into what is known as multibacillary disease. The other ones are paucibacillary. In other words, if you take skin smear, you may not easily find them. Pathologically, you can determine. But in these ones, the number of mycobacterium leprae is quite high. So this
is borderline lepromatous. Is that because you can now feel the lesion?
You can feel the lesions. They are quite extensive as well. If you take sample, there is a central healing. This is a patient who has been put on leprosy treatment. And you can see the central healing. In the middle, they are healing, but initially, this is a case of borderline lepromatous.
Okay. So now we get on to lepromatous leprosy, which you would distinguish because it's raised.
Absolutely. It is massive. The number of microorganisms is massive, and the damage is also extensive. There is no part of the body, by the way, that the scalp is spared, the axilla, the anal area, the groins are spared because they are hot, warmer than the rest of the body. So the hair, even the scalp, even if someone is hairless, the scalp is relatively warmer than the rest of the body. So as I said, the microorganisms multiply, favor the cooler parts of the body. So you don't find them on the scalp.
That's interesting because I've got something at home which is designed to see if my wheel bearings are hot.
Okay.
But if you shine it at a person, the scalp comes up very, very hot, and the axilla and the groin comes up
absolutely
hot. So it's actually it's for a car, not for a human, but it's good diagnostically.
Yes.
So you said this is the majority of leprosy.
The majority of something like 80% of leprosy patients develop lepromatous type. So yes, it's a preponderant majority.
Do you think we're missing the tuberculoid leprosy?
Oh, absolutely, because I think that's why we can't afford, because leprosy is preventable. Unlike other diseases, if deformities emerge, they actually are for life. And the most debilitating thing about leprosy is actually the stigma. A leper in Europe, they had to cover their faces, had to have a bell to beg, and people pooh-poohed them, completely avoided them. So they rang a bell to be able to get some food from individual patients. So they were actually, they killed them in some instances. They were completely, there was a penal colony, which I had the good fortune of visiting in. The Romans had a penal colony in a place called, what is this place?
In Europe?
Yeah, in Europe, in Greece, actually, in one Greek island in Crete. It's called Spinalonga. So all lepers were kept in those areas. And that was actually, it made sense. It was a physical isolation. They knew that it was an infectious disease. So they physically isolated them. When I visited it in 1978, fortune hunters would come to steal the bones to study whether or not actually it had affected bones a few hundred years ago.
Well, talking about seeing leprosy, I've recently been to Victoria Falls, and outside the shoe shop, which is ironic getting on to what we're going to talk about, the shoe shop's called Basha, there was a man with clear leprosy of his feet.
Yes.
And he couldn't walk, he was using his hands to walk. So, it's not that this doesn't exist in our communities. So getting on to nodular lepromatous leprosy, can you take us through what, if you saw somebody that looked like this, this gentleman had more problems with his feet, but his face was also affected. Can you talk us through the signs that you're seeing?
Absolutely. Now you can see these are multiple, the skin is sagging as a result of the weight of Mycobacterium leprae. Every single fraction of his skin is steaming. A gram would contain between 1 million to 100 million Mycobacterium leprae. So it's completely deformed, the line of fishes. As you can see, there is a difference, the left and the right eye. The left eye does seem to be ptotic. Actually, the difficulty is the right eye. He can't actually close the eyes. There is ectropion. The lower eyelid is actually slightly sagging, as you can see. No, his inability to close the eye has effect as a result of two things. The normal eye normally blinks about 4 times per minute. The idea of blinking is when the eye dries out, the corneal nerves of the nasociliary nerves, ophthalmic nerve, send messages to the brain as well as to the spinal cord to say, look, do something about it, my eyes are desiccating. So a message is sent to the cortical centers, and the cranial nerve number 7, which supplies the orbicularis oculi muscle, would send messages to blink, to close our eyes. And that's how the eyes are moistened every 3-4 seconds normally.
So if you ask this man, because the disease definitely seems to be worse on the right.
Exactly.
If you ask this, looking at his ear, if you ask this man to close his eyes, would he be able to close
No,
on
he
the right?
cannot.
The disease looks like it's on the left, but it's actually worse on the right.
Absolutely. So there are 2 components. One, the ophthalmic nerve, which is the afferent nerve sending messages that the eye needs to be closed, no longer works because they are affected. So there is no sensation in the ophthalmic nerve itself. So the cornea does, the cornea, the sclera do not sense anything at all, that there is something wrong with them. So the eye simply does not blink. It does not send messages, but even if there was a message sent, the facial nerve has as well been compromised. It cannot close the eye. The orbicularis oculi muscles cannot close the eyes. So the net result is the eye will be exposed to the elements. Over time, the eye simply dries up.
This man's going to go blind.
Exactly. So the eye cracks, superinfection sets in. He already has actually signs of cataract formation. So,
and this is completely preventable.
Absolutely, completely preventable. By early treatment and early diagnosis, you can completely. This is another case of these are papular lesions, also teeming with Mycobacterium leprae.
A lot of people diagnose that as papular acne.
Oh, absolutely. In fact, it could as well be mistaken for something barbae, folliculitis barbae. I mean, when people shave, they could develop that. So, yeah.
Okay. So obviously, what I wanted to ask you was, can tuberculoid leprosy result in neurological damage?
Oh, absolutely. Absolutely. Unless it is treated. who have got a case of tubercular lesions affecting only nerves. I had the good fortune of seeing a patient in India who had no cutaneous lesion, but he had what they call pure neural leprosy. He had the radial nerve was inflamed, actually quite thick, and had developed a wrist stroke. So you had actually this tuberculoid lesion affecting only the nerve. By treating it, we could completely reverse the condition. Otherwise, you'd have complete paralysis.
That's very. You need to treat it to prevent it.
As easily as possible. Within a couple of days, actually, you sterilize them by putting them on rifampicin. Rifampicin within weeks, the number of you render them non-infectious. Tuberculosis obviously is not infectious, but the other ones, the borderline lepromatous and lepromatous, by putting them within 2 weeks, actually, you render them non-infectious.
And how quickly does the neuropathy?
The neuropathy, of course, it takes quite a while. You can't reverse the damage that has already been done. It's reversible. But you can curtail the progress of the neurological condition by treating it early.
This person obviously hasn't been.
Yes.
So now what's happened here is obviously they've had damage because they've got no sensation and they've had infection.
Absolutely. Now, this individual patient must have had a multiple injury as a result of the radial nerve must have been involved, the medial nerve, the ulnar nerve. When you have got paralysis thereof, as you can see, there is complete atrophy of the dorsum of the hand on both sides, and the same thing applies to the other one. So we use the hand for a number of conditions. Because she has lost sensation, she must have been dealing with, hot things. She wouldn't feel the sensation. Sharp objects. These damages have been caused by staphylococcus, not by the Mycobacterium leprae itself. It developed osteomyelitis and other infections as a result of loss of sensation. She developed wound.
And she's not aware of it.
She's not aware of that, exactly.
And then the digit falls.
Absolutely, the digit falls off the bone. Similarly, as you can see, the complete atrophy of the palm of the hand. Yeah, complete atrophy. And we've got clawing as well. Now the extensor muscles have been completely wasted. So what we have is clawing of the fingers because the extensor is completely paralyzed. She has got medial nerve palsy, ulnar nerve palsy, as well as radial nerve palsy. So the skin is as well very, very dry because there is virtually no sweating.
And if you were to examine this patient, they would have no sensation.
Absolutely no sensation. It's dry. Yeah, and you can see it's complaining. The digits are completely falling off.
The deformities are caused by the neuropathy.
Absolutely, as you can see, the dorsal
and the wasting in these hands is characteristic.
Exactly. So you have got not only sensory loss, but you have got muscle loss, atrophy as well as a result of motor loss.
So something you said that was very interesting earlier is that this is completely preventable by wearing shoes.
Absolutely. This, even if they were anesthetic, by wearing proper type of shoes, they call it microcellular rubber, which is impervious to the thorn. Usually people rural area, they've got thorn and glass and that sort of thing. You can prevent the wound from ever emerging. So you can then, this was a very, very good example, for instance. It does not cover the whole feet, but it does cover actually the dorsum of the feet, the sole of the feet.
And that's makeshift shoe. It's an excellent solution.
Exactly.
And very affordable.
Yes, very affordable. Yeah.
Solution.
Yeah.
So this guy's obviously got the digit problems.
Absolutely.
And we're going to go through the ocular.
Exactly. The absorption, yeah. Now,
so can you talk us through this?
Yes.
This slide.
Now, this gentleman or lady, I can't actually see. She has got what they call also madarosis. That's actually loss of eyebrow. As you can see, there is some loss of eyebrow. The patient can't close the eyes as well. As you can see, the eye on the right-hand side cannot close, a condition called lag of thalamus. Lag of thalamus in Greek, apparently, I have no idea, but rabbits apparently do not close their eyes when they sleep. So, but the net result is because the eye cannot close, they are exposed to the elements. It can desiccate, dry, and the cornea can crack and invite other microorganisms to set in and destroy the eye. And beyond that, as you can see, the eyelid on the right-hand side is the eyelashes are actually getting inward. They are inverted. So they cause a condition called trichiasis. They rub on the sclera as well as the cornea.
You see on this, there's a corneal ulcer on this.
This is a corneal ulcer. Yes.
Is that caused by the eyelashes or by drying or both?
Well, it is most likely by the eyelashes. It does not show much because we haven't seen it. It can, by virtue of actually not being able to close the eye desiccates. It becomes dry. The normal eye, that's why when you operate on someone, a lengthy surgery, you actually drop saline to be able to make sure that the eye does not desiccate. Exactly. Look, yeah. So
I prefer local.
yes. So it is actually the drying as a result of not being able to close the eyes. As I said, we are unable to close the eyes as a result of two conditions. The nasociliary nerve, the corneal nerve, will not send any messages to say that the eye is dry. We need to blink. That is one component. The efferent one is the facial nerve. It cannot close. The orbicularis, oculi muscles cannot close as well.
One of the other signs that I didn't realize was that these synechia that you get within the eye cause pupillary abnormalities.
Absolutely. Now, this as a reason, as a result of usually when you have got a massive amount of immune system, the humoral immunity would be all over the place, actually within the blood circulation itself. So the eye normally, there ought not to be any adhesion between this is the iris, and behind the iris is the lens. So now in front is the cornea. Now what we see is actually this is a posterior synechia. There has been adhesion between the lens and the iris.
The easiest way to diagnose this would be to shine a torch in the patient's eye.
Oh, absolutely. Now there is no light actually. This individual patient, as you can see behind, is actually we can't see the lens. It's completely translucent. As you can see, it's completely cloudy. The lens is behind that one. You can't see it.
Okay. So getting further on, we obviously want to prevent blindness.
Absolutely.
So the first thing we've got to do is make the diagnosis.
Early diagnosis and early treatment, and to let individual patients know early on, they wouldn't have any difficulty closing their eyes as well. So when there is if there is any sign of ocular involvement, they could even close their eyes with their hands. Can do that. So, but invariably it is at a very later stage. So if we treat individuals early enough, none of these complications must arise. In leprosy, we live with the disease for the rest of our lifetime once we develop deformities. That is something that we will be identified by. So we need to prevent the stigma that goes with it and the handicap as well. Now, this is a case of lepromatous leprosy. Erythema nodosum in an individual who's got lepromatous leprosy. She has developed a massive amount of immune system. the immune reaction has set in. So to develop, it's quite painful, by the way, these lesions.
If you see a case of erythemanidasm, you need to go looking for tuberculosis or leprology.
Absolutely. It's interesting that you say that. We need to undress a patient, a skin examination that does not include a complete, we need to examine the entire skin.
Well, it's the biggest organ in the body.
Absolutely, the largest organ in the body in terms of weight as well as in terms of surface area. So we need not only that. I remember in Malawi, there was a patient who had schizomula, as a result of cystosomiasis of the spine. There was paralysis, and you could actually see the deformity at around L4, L5. So really taking the trouble to undress someone, look the entire skin is very, very important in leprosy as well.
And the most important thing is there is no blood test for this.
No.
So the story of the 5-minute consult with a quick blood test.
Absolutely.
Will the ESR be very high in lepromatous leprosy?
It would be high, yes.
But not specific.
Not specific. I mean, ESR is raised in TB in quite a number of conditions anyway. In TB as well, it's ESR raised. So, yeah. So these are diagnosed.
But I've now got a patient and I've got a skin lesion, and I now take a skin biopsy or I do a skin smear. Or you said that we should be taking smears from the nasopharynx and
from the nose, from the nasal scraping, from the lesion as well. In lepromatous leprosy, you can take actually from the lesions, from borderline as well, from the lesions, but the earlobes are prolific. And any lesion in lepromatous, from any lepromatous lesion from the nodes, you can take lesions. It will be positive invariably.
Okay. You'll see gram-positive bacteria?
Gram-positive, as you can see, these ones are red. And this is red because whenever we take a sample, it is subjected to the Ziegler-Nielsen stain, which includes carbon-fuscin as well as safranin. Safranin is a red yellowish artificial dye, which the microbe of the cell wall would take in. Once the Mycobacterium leprae takes that one in, it won't decolorize if you put it in an acid medium or alcohol medium. That's why it's called acid fast and alcohol fast. So you can see.
So if you put alcohol in the smear, it will stay red.
It will stay red. And so you can see the rods actually beautifully. Yeah. So this is.
If you don't do this, you will miss diagnosis.
I mean, this is a gold standard actually. Establishing that would make absolute sense. But you can as well start treating individuals on the basis of clinical findings. That
we've highlighted clinical because you must
absolutely,
you must have a high index of suspicion, and you must
exactly
look for the neuropathy.
Yeah, the neuropathy, the anesthesia on the skin, the loss of sweat, anhidrosis, and the major nerves that are affected are the greater auricular nerve around the neck. We have got the radial nerve, the medial nerve, the ulnar nerve. In the legs, the peroneal nerve and the posterior tibial nerve are very, very important.
Are they most commonly affected?
Oh, they are commonly affected, and they are quite large, palpably large.
Okay. I think a lot of anatomy students wouldn't even know where the posterior tibial nerve.
Well, I asked students, a while ago, my medical students, I used to take them to Beatrix Hospital. And I said, any medical doctor, in fact, quite a number of our doctors wouldn't even tell you that the olfactory nerve is the number one, the optic nerve is the second one, the oculometer, which moves, I tell them, well, that it moves all the eye, that's why it's called oculometer. The trochlear, in that order, the abducens, trigeminal, facial, glossopharyngeal, vagus. Vagus is the third. No, the ninth. The tenth. The tenth is the tenth. Glossopharyngeal, hypoglossous.
As well.
Yeah. I remember it in what I was taught is an old Olympus towering top, a Finn and a German viewed some poops.
I wouldn't be able to remember that.
Well,
I remember it.
helps me actually. Yes, Hops is the hypoglossous. Yeah. So the seventh nerve and the trigeminal or the Pepys nerve are involved in leprosy. The trigeminal, it was not the motor component. It is the ophthalmic branch. It's a mixed nerve are affected by leprosy.
So we now need to get into treatment because I'm quite aware of time. And I remember in the mid-90s when therapy came into HIV, the funerals.
They call it combination, but the proper term, they stole it. It is multidrug therapy.
No, I'm 100% on your page. So in 2020, Dr. Peter McCullough described sequenced multidrug therapy with COVID, but we're talking multidrug therapy, and you're saying rifampicin you only need to treat with 600 milligrams once a month. Yes. Clofazimine you only need 300 milligrams once a month, and dapsone 100 milligrams daily.
These, yes, exactly. These are for multibacillary disease, where the individual has virtually no resistance. I mean, another important thing I need to mention. In any infectious conditions, there are three important factors. The size of the inoculum, the number of organisms to which we are exposed is absolutely crucial. The fewer the number, the less likely we are to be affected. The more, the greater number of microorganisms, the greater the risk is. That's number one. The second is what is known as the virulence of the microorganism. Some are very virulent and some less virulent. Obviously, the more virulent, the greater the risk is, whatever that infection may very well be. The third factor is the individual immune system.
So the susceptible host.
Absolutely, exactly. The susceptibility is a function of age, gender, among others, but our own immune system. 95% of humanity, as I said, is completely refractory to
anyone who's got a deficient immune system, whether it's nutritional, whether it's HIV.
Cellular, not the other one. Cellular immunity, that is T-cell function.
So any patient on chemo, for example, could reactivate leprosy?
It could absolutely reactivate leprosy, exactly.
Okay. Yeah. And so getting through the chain of infection, the infectious agent is obviously Mycobacterium leprae.
Yes.
The reservoir, which we've gone into, will be humans.
As the main one, obviously, are humans.
Okay, but we also know that
in zoonotic conditions in the North America, the 9-banded armadillo has been found to be the main reservoir other than man.
It's very interesting.
Yeah.
So the portal of exit?
The portal of exit is the respiratory system as well as the skin. We are actually, every time a skin bursts, millions of mycobacterium actually falls off on the ground. And within about 2-3 weeks, they can as well be airborne as well.
So we know that with Mycobacterium tuberculosis, it is killed by sunlight.
Yes.
Which is why the sanitariums in Africa worked, because people were put into the sun. Does Mycobacterium leprae also get killed by sunlight?
Oh, the sunlight, yes, but they are far more resistant. That's why they can stay for as long as 2 weeks.
Okay. So, so the exit portal is if you're exposed to the Mycobacterium leprae, it is either from a skin lesion or the respiratory system of a host or a surface.
The respiratory system is the main one.
But is that the inhalation?
As someone speaks, sneezes, coughs, you would be exposing, individuals to millions of microorganisms because there are quite a number of in the nose itself.
So it's the nose rather than the lungs?
No, exactly, the nose.
Okay.
Yeah.
So the portal of entry is the other respiratory system. That means that transmission is aerosol. And the susceptible host of the vitamin C, D, zinc.
Well, the all three, yes. I mean, I think the most important thing is in the 95%, humanity is spared as a result of a very, very strong cellular immunity people have. But our immune system can, for a number of reasons, could be compromised as a result of co-infection with, say, HIV, for instance.
Of how they say putmin.
We also know that some of these injections are causing vaccine-associated immune deficiency.
Absolutely, they can as well do that. Nutritional conditions, age, vitamin D deficiency, all that could contribute, obviously, to waning of our immune system. Even if we are affected, the type of leprosy we acquire can as well be determined by our immune system. If our immune system is very, very poor, we are very likely to develop the more fulminant one, florid one, leprosy.
My goodness. Well, we've come to the end of the hour, and there are so many questions I think the audience will want to ask you. But I think that this slide probably says it all. And I'd just like to thank you.
Excellent.
And I'd like you to take us through this patient with a experience-based medicine and a clinical eye.
Excellent. Thank you very much, Jackie. As you can see, this gentleman, actually, there are no eyebrows at all. It's a condition called madarosis. And he's not able to close his eyes. He has probably only light perception. He has lost, he's functionally blind. He can't, as you can see, the one on the left-hand side is a sclerocorneal junction is extremely inflamed. You can see he has developed something called pannus. Pannus is when neovascularization of the cornea. The cornea normally, as Jackie had mentioned, it is avascular. It gets its oxygen supply from the from the corneoscleral junction by diffusion. Now, as a result of corneal injury, neovascularization had set in. So it has gone to the cornea, completely made the cornea completely translucent, not transparent, translucent. A normal eye should have a very transparent, clear cornea to allow light to pass in. So both eyes are actually compromised. He has got pannus. The cornea is no longer crystal clear, and we can't see the lens. Most likely the lens has as well been injured, cataractus, and is virtually blind. And as you can see,
he's got the hands quite clear. And interestingly, as you said, his scalp is completely
exactly. Look at the skin as well. Do you see that? The skin they call it fish skin. This is as a result of lamprey. When individuals take lamprey, they have got that sort of skin. So they call it.
Well, I think we should get you to teach clinically and teach medical students. And this highlights the importance of knowing your anatomy. The reason I know about a posterior tibial nerve is because I do posterior tibial nerve blocks. So when you are treating something on the sole of the foot, it's very difficult to suture the sole of the foot. And so what you do is you put in a posterior tibial block and you anesthetize the foot before you inject local so that the patient doesn't experience severe pain. But other than that, I probably wouldn't be able to draw the ulnar nerve or I know the median nerve, and I know obviously the wasting that comes with carpal tunnel syndrome. But you've just given us a course in neuroanatomy, and we haven't even touched on the liver and the other organs that can be involved as well.
Exactly. Actually, yes. If I could say as well, it can cause gynecomastia in men, and it can cause atrophy of the testicle. So infertility is not uncommon in lepromatous range of the disease as well.
Okay, so someone who's got abnormal liver functions, testicular
Absolutely,
atrophy,
absolutely,
gynecomastia,
absolutely. And
you
their
need
man,
to be looking for it.
yes, their manhood is compromised as a result. So they, yeah. So particularly in our part of the world, where parenting is such an important condition, it's not only deformity, but they also
social stigma.
Social stigma.
And I went to a talk recently on erectile dysfunction, and nobody mentioned leprosy once.
Yeah, but leprosy as such, it is not erectile. They don't even talk about it. Definitely, in fact, there is the sperm production is so limited. They are azoospermic, the number. So they wouldn't even think about it. So they wouldn't
But if you get testicular atrophy, don't you get a low testosterone? And
absolutely, yes, exactly as well. Yeah.
And that's why they get the gynecomastia, because they're estrogen dominant.
Absolutely.
So interesting. I could ask you questions all evening, but we've reached the end of the hour.
Thank you very much.
We're going to stop the recording now. Thank you, everyone. I'm just going to read a couple of questions from the chat, Dr. Debru. Thank you for joining us, and thank you for your wisdom. One of the questions from the chat is, if you've got a very sick patient, can that patient transmit leprosy before multi-drug therapy is started? And if you start multi-drug therapy, how long must they be on it before they're no longer infectious?
Can you hear me?
I can hear you.
Yes. Yes. May you repeat that question, Jackie? I didn't properly hear.
May you please repeat?
Okay. So the question is that if somebody is very sick, are they able to transmit leprosy from a skin lesion before they have started multi-drug therapy?
Well, the disease isn't actually the skin. Someone can shed Mycobacterium leprae, but we do not acquire Mycobacterium leprae directly from the skin. It is invariably through respiratory system. So it is as a patient who has got a multibacillary disease. In other words, a borderline lepromatous or a lepromatous. These are individuals which shed Mycobacterium leprae as they sneeze, cough. It is under those circumstances that the organisms are airborne, not from the skin as such. It is possible that we shed Mycobacterium leprae can as well indeed from the skin. It can eventually be airborne, that possibility exists, but invariably it is through the nose that we acquire it as a droplet infection.
Thank you for that, Dr. Debru. How many days would a patient have to be on therapy before they would transmit? Because obviously doctors need to protect themselves as well. So first of all, if you were treating a lepromatous patient, would you take prophylaxis? Sorry. And secondly, if you started treatment on a patient, how long would it be before they no longer were infectious?
It's interesting, well, to answer, doctors or health professionals who are exposed to particularly lepromatous type of disease can minimize the risk of infection by just taking a single dose of 600 milligram of rifampicin. That in itself can virtually minimize the risk of infection by about 70%. That is among individuals who are in very, very close proximity with patients who have got the multibacillary disease. In terms of treatment, if you put an individual on the 3-drug regimen, the dapsone, which is 100 milligrams per day, clofazimine, 300 milligrams per month, and rifampicin, 600 milligrams per month, within actually taking the initial dose you render the microorganisms, you may not completely eradicate them, but you can fracture them. You can render them completely useless in terms of infectivity. So a single dose can chemically isolate an individual from any risk of transmitting the infection to others. So it's a wonder really treatment in that respect, the new MDT schedule. A single, just after about a month, you minimize the risk of infection completely. As we said, in multibacillary disease, the duration of the treatment is for a year, 12 months, which used to be for life, actually, in olden times with Dapsone. For the rest of their lifetimes, they had to take Dapsone 100 milligrams per day. And in postbacillary disease, you only take it for about 6 months. So it has drastically changed the leprosy landscape, the multidrug therapy, in terms of infectivity, because by treating individual early on, we completely sterilize him or her. So the most important arm of treatment is not only to treat the individual in infectious diseases, but to prevent the risk of infection. So you do that, yes.
So, Dr. Debru, if I had a patient and I saw them with leprosy,
Yes.
would I, with their contacts, with their people living in their home, would I swab their noses and then give them a single dose of rifampicin as a preventative, or would I just give them all rifampicin just to be sure?
We have got an active, what they call it, an active case detection and a passive case detection. An active one is when the medical fraternity does go in a house-to-house search. That is no longer the case, but individuals who have a lepromatous family member could be given rifampicin as chemoprophylaxis. And of course, you can ask them to come over and be seen once in a while, but the chemoprophylaxis in itself renders about 70% of, it does confer about 70% of protection in a lifetime. Can you imagine? In a lifetime, just taking a single dose of 600 milligrams of rifampicin can do that. But individuals can be asked to come and be seen. So in lepromatous family members, is important indeed to keep that, to keep that in mind. That chemoprophylaxis is an option.
Okay. So I don't know if Dr. Nasser is still on the phone. I'm going through the participants. Dr. Nasser, are you still on the call? I think he's dropped off. He's in Canada at the moment. So I was just interested because he's adamant that we shouldn't use rifampicin outside of TB.
Absolutely.
Based on the fact, but we should use it to prevent leprosy. One of the other questions I'd ask you is, what about
TB as well?
boosting the immune
TB.
system in the family members?
Sorry, Jackie?
What about boosting the immune system in the family members?
Well, interestingly, it's good that you raised that. Individuals who had been given BCG, Bacillus calmette guerin, which is attenuated Mycobacterium TB, although its protective value in terms of TB is not high, amazingly, it does wonders to protect someone against leprosy. So an early immunization with BCG, by and large, contributes immensely to reduction of the risk of infection in leprosy. So BCG protects against leprosy, not against TB itself. The Bacillus calmette guerin, I think either they are Belgians, I think they are French scientists who attenuated the TBC, it is immunogenic, but its immunogenicity does not protect against acquiring tuberculosis. It does protect against leprosy. So leprosy can as well be prevented substantially by having been exposed to BCG early in life. It
That's
boosts the
very, very
immune
interesting.
system. Yeah.
So those of us that were vaccinated with the BCG at birth
Yes.
are probably going to be protected, even if our immune systems get old and tired, we will still probably be protected against leprosy.
It does indeed. It does protect against leprosy. Another thing I probably need to mention is Mycobacterium leprae it can't be grown on artificial medium, but on foot pad of mice, it can multiply. So one of the diagnostic measures, if we do not have sufficient amount of Mycobacterium leprae, particularly in paucibacillary cases, is if you take samples and inject it in the foot pad of mice, they are susceptible by and large. So they could develop a similar sort of lesion, lobular sort of lesion in the feet. And you can harvest from that. You can take Zellner stain, make a slit skin exam, and you'll find teeming Mycobacterium leprae in them.
So, Dr. Negash, if we were to diagnose someone that we suspected to have leprosy based on an anesthetic anhydrotic skin lesion,
and hypopigmented as well.
so if we took a sample, would you recommend that we start treatment before we get the result?
Well, the skin, as I said, yeah, in paucibacillary disease, in other words, in tuberculoid range of the disease, what is known as tuberculoid, these are individuals whose lesions do not exceed 5 in number, and they are usually asymmetrical. In those circumstances, if you have got anesthesia or hyposthesia, if you have got hypopigmentation, as well as anhydrosis, if the skin is dry, that can as well be corroborated by close proximity to someone who has that leprosy. So you can start treatment, you can take skin smear, and immediately you can take skin smear and take a biopsy for pathology. And in the meantime, you can start individuals on multidrug therapy. Those 3 conditions, anesthesia, hypopigmentation, and anhydrosis, these are pathognomonic. So on that ground alone, you can start the treatment for paucibacillary disease.
And Dr. Negash, from a practical point of view, if I was to write a script for rifampicin and for multidrug therapy, would it be accepted as a private script in a pharmacy, or does the patient have to go to a government institution to get rifampicin?
Yes, well, by and large, leprosy the treatment is free. And in fact, to prevent the risk of misuse, as you know, rifampicin has been misused for quite a number for gonorrhea. It has been found to be very, very effective. And individuals who develop folliculitis, Barbie as a result of staphylococcus, furunculosis, even simple conditions like acne are absolutely susceptible to rifampicin. So there has been a misuse of the disease, the drug. So in leprosy, they have got something called DOTS, directly observed therapy. So that used to be, particularly, it is to prevent rifampicin misuse. So it has got to be taken at a medical center. And leprosy treatment is freely available, by the way. So it need not be acquired from a pharmacy. It's available under other circumstances.
Great. That was incredibly useful. Thank you, Dr. Negash. I'm quite aware that we've gone over time by about 15 minutes. So, Obi, are you still on the call? No, he might have dropped off.
Good evening.
Thanks.
Good evening, Dr. Jack. I'm still on the call.
Oh, great. Obi, would you like to close and then we'll cut the call in about 10 minutes time or earlier?
Sure. I think we can close the call in the next 2 minutes after closing. Okay. Colleagues, extended gratitude for being in our audience. Just a second. Dr. Negash, thank you very much for taking us through this evening's session. It was a great pleasure to have you lead us. Extended gratitude again, Dr. Jackie, for having moderated this session. Colleagues, I've also noticed the messages in relation to the link, that the link has expired. It was only running for an hour. So you will not be able to complete your details for this session if you hadn't completed those up to 7:30. But the link will be opened up again for next week's session. We look forward to hosting you again. A very good evening to you all. Please feel free to exit. The session is now over. Thank you.
Thank you, Obi.
Thank you.
And